So we'll continue with the guidelines for LV systolic function, and this is the most current guideline. We spoke about strain, and we define strain as the percentage change in length. And we use the Lagrangian strain when we doing cardiac evaluation, and it is defined as the change in length of an object within a certain direction, so it's a vector quantity relative to its baseline length. And as we said before, it's LT minus L naught divided by L naught, where LT is the length at a time at an arbitrary time, and then L naught is the length at time zero. When the heart contracts longitudinally, the base moves up to the apex, and that accounts for a majority of or a significant portion of our cardiac contractility, the base moving up to the apex. If we use the longitudinal length from the base to the apex in diastole, and if we use that as L naught, when the heart contracts and the base moves up towards the apex, then the systolic length, longitudinal length, that's LT, and that's going to be less than L naught. So once you put that in the equation, you're going to get a negative number. So basically what we're saying is what percent of shortening the heart does. And we divide the heart into segments, and we look at the different segments. We can also give a global longitudinal strain, and that's basically just looking at the diastolic length and the systolic length and plug that into the equation, and you get a strain value. And we can do strain either using Doppler techniques or speckle tracking echo. Speckle tracking echo, which is not angle dependent, is the recommended modality or method. When we look at ejection fraction, we talk about the normal range, mildly abnormal, we talk about moderately abnormal and severely abnormal, and we classify that in males and females. So the normal ejection fraction, we say the wide range, it's probably 52 to 74, where 52 to 72 is the male and 54 to 74 is the female. Mildly depressed, mildly reduced, or mildly abnormal LV systolic function, ejection fraction is about 41 to 51. And then moderately abnormal is about 30 to 40. And severe, so anything less than 30 is severely abnormal. And then for the female, the range are close, 54 to 74 for normal, mildly abnormal, 41 to 53, moderately abnormal, the same, 30 to 40, and severely less than 30. We have a more detailed session on left atrial enlargement, but left atrial enlargement is very, or the evaluation of the left atrium size. And the current method is to do left atrial volume assessment, and not only left atrial volume assessment, but you have to index it. So especially if you're doing exams, if you don't know this, you're going to miss one or two questions. Left atrial volume is not a straightforward volume. You have to index it, and you have to know the normal value. So when you index the volume, it's milliliters per meter squared, and it's normally up to about 34. The normal left atrial volume is up to about 34. So if it's 35 to 41, it's mildly abnormal. And if it's 42 to 48, it's moderately abnormal, and it's severely abnormal. Or if you want to say severely enlarged, anything greater than 48. And you can see it's very similar for males and females. But left atrial volume assessment is extremely important. Okay. Now, most of you know the concept of segmentation of the left ventricle, and we divide the left ventricle into segments, and you have to know the segments. Okay. We have 16 segment model, we have a 17 segment model, and we even have an 18 segment model. Most literature will talk about the 17 segment model. So for the assessment of regional LV function, the ventricle is divided into segments. Segmentation schemes should reflect coronary perfusion territories. So one of the main reasons for looking at the heart into segments is because of the blood flow. We can relate the blood flow to the different segments. And what we do when we look at a segment, we classify it as normal, or is it abnormal? So if it's normal, that means it has normal thickening and normal motion. If it's abnormal, then we talk about hypokinesis. It's not thickening as much as it should. If it's akinetic, that means it's not thickening at all. And then we talk about dyskinesis, which is, thinning, dilatation, moving in opposite direction. So there are 4 classes of regional LV function, and you have to know about those. We're also gonna look at myocardial mass because it's important when you start talking about the different types of hypertrophy. So we'll talk about a little bit about myocardial mass. And so this is our 16 segment model. And this is what we call a polar plot. We essentially combine everything in one diagram. Those of you who don't have enough or didn't have the background information on segmentation or regional wall motion, then you need to look at the original lectures that we gave to have an understanding. But this is what we call a polar plot where we combine everything. The inner circle is the apical region of the heart. So this inner circle is the apical region. Then just outside of that, this is the mid segment at the level of the papillary muscles. And then this outer segment is what we call the base of the base, which have the mitral valve in place. And the reason why we have this is because this is the RV wall and the RV cavity is right there. So this is the left ventricle. This is the left ventricle, and we put everything together so we can just look at it and determine, if segment 1 is abnormal, we know where segment 1 is on the heart. So again, the inner circle is the apex. The mid segment is just outside of that, and that's at the level of the papillary muscle. Then just outside of that, we have the basal segment at the level of the mitral valve. So how do we name these segments? Relatively simple. So if we take the base at the mitral valve level, the uppermost segment is the apical segment. The lowermost segment is the inferior segment. So the anterior segment. So this is the anterior segment and the inferior segment. So anterior is above, inferior is below. So this is the basal, and the uppermost is the anterior, and this is the inferior. Now, this area is the septum. So segment 2 and segment 3 is the septum, but Segment 2, which is close to the anterior wall, is the anterior septum. And segment 3, which is closer to the inferior wall, is the inferior septum. And then this is the lateral wall over here. 6 and 5, or 5 and 6, is the lateral wall. 6 is close to the anterior wall, so it's the anterior lateral wall. And this 5, which is close to the inferior wall, is the inferior lateral wall. So you name all 6 segments of the basal. So this is the basal, this is at the level of the base, and you have the anterior, the inferior, anterior septum, inferior lateral, anterior lateral. Simple. The mid segment has similar nomenclature. You name it the same as the base. So the mid segments are at the level of the papillary muscle. You have the anterior wall, inferior wall, the septum, which is divided into anterior septum, inferior septum, the lateral wall divided into anterior lateral wall and an inferior lateral wall. And then, so we move from the mid segment to the apex. So inside the innermost circle is the apex. And we divide the apex into anterior wall, 13, inferior wall, which is 15, septum, which is 14, and the lateral wall, which is 16. So we combine everything and we call it it's a polar plot. So this is a 16 segment model, as opposed to the 17 segment model where because if you look at the apex of the heart, you can, if you cut just the apex, you get what we call an apical cap. You get an apical cap, just the top of the apex, and we call this the apical cap. And then the apex itself is right there, same as before. The mid segment at the papillary level muscle, and we went over the naming of that. And then at the base, which is at the level of the mitral valve, and we went over the naming of that, similar. And we don't really use this 18 segment model, but there's an 18 segment model. All right. What about visual assessment of the heart motion? In echocardiography, regional myocardial function is assessed on the basis of the observed wall thickening and endocardial motion. So when we look at the heart muscle, we look at thickening of the muscle and motion as well. The problem is motion, because you may have a segment or a region which is infarcted or ischemic, and it's not thickening, but it has motion. And the reason why it has motion is because the normal areas around is going to pull it. So it gives you the impression that the motion, it has good motion. So because myocardial motion may be caused by adjacent segment feathering or overall LV displacement, regional deformation, which is thickening and shortening, should be the focus of the analysis. So I hope you understand why we delve a little bit deeper into looking at the segment, because you can't use motion by itself. Okay. So as I briefly went over, we have a normal segment and we score it 1. You can, even if it's hyperkinetic as well, we give it a score of 1. And then we have a score of 2, which is hypokinetic, that is reduced thickening. So remember, when we're talking about motion, thickening is one of the main things that we look at. So hypokinetic segment, we'll give it 2. And then if there's absent or negligible thickening, we call it akinetic, and we give it a score of 3. And then a score of 4 is dyskinetic, that is systolic thinning or stretching. Example is aneurysm. We used to divide, we used to have a 4 and a 5, and then, but that the current guideline just recommends a 4. So when we're looking at regional walls or segmentation of the heart, there are 4 classification of motion: normal or hyperkinetic, 1; 2, hypokinetic, reduced thickening; 3, akinetic, absent or negligible thickening; and 4 is dyskinetic, systolic thinning or stretching. Now, there are some situations where you can have the main cause for regional wall motion abnormalities is coronary artery disease. A blood vessel is blocked, and because it's blocked, then that segment does not thicken as it should, and you have regional wall motion abnormality. But there are other conditions that can give rise to regional wall motion abnormalities, and those include myocarditis. So if you have an inflammation from, say, a viral illness, or whatever, you can, the myocarditis can give you regional wall motion abnormalities as well. Sarcoidosis is very common in causing regional wall motion abnormalities. And then stress-induced cardiomyopathy, the so-called Takotsubo cardiomyopathy. So these are some conditions that can give you regional wall motion abnormalities, and it does not involve coronary artery disease. And you can also get abnormal septal motion. We talk about a paradoxical septum, and you get that in patient with a left bundle branch block, or if the patient have a pacemaker in place, RV pacemaker, or if they had previous heart surgery post-op, they can have abnormal septal motion. Okay. Now, to give you a somewhat better insight into regional wall motion and the different views of the heart. So this is our polar plot down below, okay? And of course, we talk about the anterior, the inferior. We talk about the anterior septum, the inferior septum, that. Now, or let's do a 4-chamber view first. The 4-chamber view is essentially when you cut the heart along this plane, okay? So you cut the heart along this plane, and that's how we get our 4-chamber view. This is our septum, but it is the inferior septum because you're cutting the heart like this. So this is our inferior septum. And of course, we have our basal inferior septum, which is closer to the mitral valve, the mid inferior septum, and the apical inferior septum. And then we talk about the apical cap, which is just a tip. And then this is the anterior lateral wall, because this is the cut when we get in our apical 4. So you can see we cut across the anterior lateral wall. So this is the basal segment, which is closest to the mitral valve. So this is our basal anterior lateral wall. This is the mid, and this is the apical. So this is a 4-chamber view. It is because when we cut the heart, we cut it along this plane, as opposed to the 2-chamber view. The 2-chamber view, we usually say this is the inferior and the anterior, but when we look at the heart, we cut the heart straight from the anterior straight to the inferior. And that is why all of this area is the anterior. We have the basal anterior, the mid anterior, and the apical anterior. And then we go down to the inferior. We have the basal, the mid, and the apical inferior wall. Okay? Anything closest to the mitral valve, that's basal, we said that. Okay? The mid and the apical. Now, our apical three-chamber view, or the long axis view, this is a cut along the heart like this, a cut in this plane. Okay? It's a cut in this plane. So all of this area is our anterior septal, and all of this is our inferior lateral. Okay? So this would be our basal anterior septum, mid anterior septum, and apical. And then this is our inferior lateral, basal, the mid, and the apical. So if you remember how you do your cut, then you can name the segments. So you should try and master naming these segments, because it's important. And majority of the case of abnormal wall motion is because of coronary artery disease, even though we talk about myocarditis, Takotsubo, sarcoidosis. uh, they are the most common cause of regional wall motion abnormalities, coronary artery disease. So we went over the naming of them, and this is just the naming. So the apical cap. So again, this is our inferior septums. You have the basal, the mid, and the apical. This is our anterior lateral wall, basal, mid, and apical. And then we have this is the two-chamber view. So your anterior, basal anterior, mid, apical cap. So this is the 17 segment model where we have the apical cap. So try to learn your segments, it's important. So we stress that the most commonly used deformation parameter is the longitudinal strain, and this is enjoying tremendous popularity and tremendous clinical utility. It's very useful. So you need to fully understand strain. So we have a global strain where we look at the diastolic longitudinal length, and then we subtract from that the systolic longitudinal length, and we divide it by the diastolic longitudinal length, and that's going to give us an overall global longitudinal strain. We can also do regional deformation measurements, and that allows us to look at just a segment to see if it's normal or abnormal. And a normal strain varies from probably minus 15 to probably minus 25. You need to get that amount of percentage. You need to get that amount of percentage shortening. So, all right. So when we look at the heart and we look at the blood vessels on the surface of the heart, so we know that the blood vessels come from the coronary sinus. The right coronary artery comes from the right coronary sinus. This is our right coronary artery there. The left main and the left anterior descending coronary artery comes from the left coronary sinus, and it has its branches. When we look at segmentation, we need to know the blood supply to that area. So when we look at our apical four-chamber view, the basal inferior septum and the mid so the right coronary artery, and some portion is the LAD. And then towards the apical, this is the LAD. The apical cap is the LAD. And then the lateral wall is mainly the circumflex and the LAD. So circumflex LAD, the apex and a portion of the apical septum, this is the LAD. And then, the mid and the basal is the RCA. This is our two-chamber view. So basal and mid is usually the RCA. And then, the anterior wall and a portion of the apical's inferior wall is the LAD. And this is our long axis view. This is our anterior septum, LAD, and then the inferior lateral wall is the RCA and circumflex. So try and get a rough idea of the blood supply. And then in the short axis view, the anterior and the septum, this is at the basal level where you have the mitral valve. So the anterior and the septum, the LAD, and then the apical lateral wall and the inferior. So this is the LAD and the circumflex, and this is the RCA and the LAD. But the inferior and the inferior septum is mainly RCA. Inferior at the mid level is the RCA. The anterior and the anterior septum is the LAD. So having a rough idea is important, because if you look at a segment and that segment is abnormal, you can determine which blood vessel is occluded, which blood vessel is involved. Okay? And then when we look at the apex, then the anterior, the septum, and the inferior. So almost all of the apex is supplied by the LAD. So when we have someone with they have a heart attack and we look at the apex is wiped out, we know it's a LAD. All right. So now we do left LV mass. So basically the mass of the left ventricle. And the computer does the calculation for you. All you have to do, once you measure the interventricular septum, you measure the LV dimension in diastole, internal dimension diastole, you measure the posterior wall. The computer put it in this equation and give you a LV mass. And LV mass is important because we index the LV mass and we relate it to something we call the relative wall thickness to decide, is this patient a normal patient? Does this patient have what we call concentric remodeling? Does this patient have concentric left ventricular hypertrophy? Or does this patient have eccentric hypertrophy? So you don't have to do the calculation for the LV mass, but you have to know the different things that goes into that. Measuring the septum, the LV internal diameter, and the posterior wall. That's one method. Okay, it's fast, widely used, well-published data. So you can do it also. You can do M motor. You can do the 2D. So this is how you measure the septum. We went over measuring the septum, LV dimension, internal dimension, and the posterior wall. So once you do these measurements, the computer put it in the equation and you'll get the LV mass. There are other methods for LV mass. The one I showed you before is probably the most common one. Now, these are some of the normal ranges for LV mass. You don't need to know all the table, what you need to remember is, so it varies for females and males. And again, most of the stuff that we do is index. So when we look at LV mass, we talk about grams per meter squared because the mass is in grams and the body surface area is in meters, meter squared. So it's gram per meter squared. So the upper limit for females is 95 and the upper limit for male is 115. So I think these are probably the only two numbers you need to remember, okay? The 95 and the 115. 95 for females, 115 for males, okay? So, and this is used in the linear method. Another thing that you need to get in order to evaluate these patients is the relative wall thickness. So you need to get relative wall thickness in order to fully evaluate these patients to see what category of hypertrophy they have. And to get the relative wall thickness, you need the septum, interventricular septum in diastole, and the posterior wall, and you're going to divide by the left ventricular internal dimension in diastole. Okay, so that's the relative wall thickness. So we use that information to class the hypertrophy or the what the patient is having in terms of, are they normal or are they having some type of hypertrophy. So the horizontal axis is LV mass, and as we said, so the horizontal axis is LV mass and the vertical axis is relative wall thickness. Okay, so this dotted line, anything above that, well, to the right of this dotted line is for females, we're talking about a mass index greater than 95. For males, mass index greater than 115. And then when we come to the vertical axis, the relative wall thickness, 0.24, that's the number you need to remember. Below the dotted line, it is less than 0.42. Above the dotted line, it's greater than 0.42. So a normal individual, which we talk about normal geometry, they will have a mass. If it's a female, if the patient is a female, then the mass will be less than or equal to 95 gram per meter square, and the relative wall thickness will be less than 0.42. So they will be in this quadrant of this rectangle. So a normal geometry, they'll have a body mass index, female less than or equal to 95, males less than or equal to 115, and relative wall thickness less than or equal to 0.42. For patients with concentric remodeling, their body mass index is also less than, for female, less than or equal to 95, and for male, less than or equal to 115, but the relative wall thickness is greater than 0.42. So that puts them into this category. We call this concentric remodeling. And then when we come over to the right, where the body mass index for females greater than 95, males greater than 115, we have two categories here. We have the patient with the concentric hypertrophy and the patient with the eccentric hypertrophy. If the relative wall thickness is less than or equal to 0.42 and the mass index, the body mass index is increased, then we call that eccentric hypertrophy. Concentric hypertrophy is when the body mass index for female greater than 95, males greater than 115, and the relative wall thickness greater than 0.42. So you should know this rectangle configuration and where the numbers go. This is how we report hypertrophy, okay? At the present time, patients, it's either normal, concentric remodeling, concentric hypertrophy, and eccentric hypertrophy. And this is just to give you an idea, a normal individual cavity size, the wall thickness. When we talk about concentric remodeling, then the wall is thick, but the overall size is probably not increased. And then eccentric, the cavity is huge, and the wall may be normal or a little thickened. And then concentric, there's tremendous thickening, and it may increase a little bit, but there's tremendous thickening. And then this is the M mode, looking at the same thing as well. So let's stop here, and next week we'll look at RV quantification, but these are the ASE recommendations. So if you're not doing these things, you need to start doing them. People who are doing an exam, this is what you're going to be tested on, because the exam is based on the American Society of Echo measures. Okay, so